like to call Dr. Nagalekshmi Ganesh, who was our colleague in Shankar Nethralaya as well. And she'll be speaking in the role of structural tests. And she'll be going on head with our guru, teacher, everything possible for all of us from Nethralaya, Dr. Ronnie George. Nagalekshmi, please. Seven minutes, Nagalekshmi.
Good morning, everyone. I'll be talking about the role of structural tests for glaucoma diagnosis and progression. The current glaucoma definitions by major glaucoma societies include the loss of retinal ganglion cells, which is essentially a structural measure. So we have the clinical assessment, disc photography, which are more of a qualitative test, and HRT, GDX, and OCT, which are quantitative. So where do structural tests outscore functional tests, and why is it the case? Various studies have shown that structural evaluation is a more sensitive measure of early glaucoma. Of note is Kerrigan et al.'s study in 2000, where it was noted that at least 25 to 35% of RGC loss is required before SAP abnormalities develop. Why is this the case? Because there is a redundancy of the visual system, which means in early stage of glaucoma, the neighboring retinal ganglion cells, which are functional, compensate for the cells that are dead nearby. So a significant structural change translates to only a smaller relative functional change. And again, the structure-function relation has been known to be curvilinear until a tipping point, until which the abnormalities are primarily in structure, followed by measurable changes both in structure as well as function. So even as early as 1991, among the OHT cohort of 1,344 patients, it was noted that in 60% the RNFL defects were detected by red-free images 6 years prior to visual field changes. Talking about the photography, it is the most commonly used method of documenting structural change, and it has also been used as an endpoint in various major randomized controlled trials. And the qualitative variables which are documented by the photographs have a higher specificity than the quantitative parameters. So this structure function discord causes the concept of pre-perimetric glaucoma, where there is a presence of characteristic glaucomatous change without presence of visual field defects. So of note is the study by the advanced imaging glaucoma study, which was a multicentric longitudinal trial which went on for 9 years, and this had the maximum number of pre-perimetric glaucomatous eyes of about 663. And it was noted that there was a significant difference between the normal and the glaucoma suspects, and also the perimetric glaucoma groups in all the measured diagnostic variables except for rim area by HRT and overall nerve fiber layer thickness by the GDX. Also, the repeatability was noted to be best for the nerve fiber layer thickness and GCC by the Fourier domain OCT. However, a study from Shankar Nethralaya published in 2021 on pre-perimetric eyes showed only a significant difference in the following parameters, which were average RNFL thickness, inferior RNFL thickness, infratemporal GCL IPL thickness, average and minimal GCL and IPL thickness. So talking about the ganglion cell complex, it includes RNFL layer, GCL, and the IPL. The new parameters like focal loss volume and global loss volume have better diagnostic values, especially the global loss volume have a higher odds ratio in early glaucoma and FLV in detecting even advanced glaucoma cases. Also, it has an edge in high myopic eyes, where it is less affected by axial length parameters and also circumvents the variation with ONH and peripapillary parameters. So talking about the role of structural test in glaucoma progression, we know a change that is when it is more than what is expected with aging and test-retest variability, we classify it as progression. Again, the advanced imaging glaucoma group went on to state that the visual field conversion was preceded by abnormal OCT in the pre-perimetric group by at least 2 years. The detection rate was definitely more with the structural test being about 38.9% versus only 18.7% by the functional test. And GCC and NFL parameter combined had a significantly better detection rate than trend and event analysis combined. Also surprisingly, while the NFL detection rate by NFL dropped in late glaucomas, by GCC remained fairly constant even in the later stages. So the same group published the data on perimetric glaucoma. Again, highest odds ratio was noted for nerve fiber layer and focal loss volume, especially in rapid progressors. Also, disc hemorrhage was known to have a higher odds ratio. Talking about disc hemorrhage, the odds of disc hemorrhage causing progression, the presence of disc hemorrhage in rapid progressors were higher when it was present along the neuroretinal rim or along the area of nerve fiber layer defect. So there were also similar other studies which prove the role of structural test in detecting progression, especially in early preperimetric and mild glaucomas, much earlier than the functional test. So why should we detect glaucoma early in these cohort? It's because like every millimeter of IOP does matter, as proved by Kim et al. Study in American Journal in 2015, where they studied 127 eyes, and it was noted that 56.7% of them progressed, and the cutoff value of 22.1% of IOP reduction best differentiated progressors from non-progressors. And considering that the progressors dropped by about 0.6 decibels of mean deviation every year, it would take about 15 years for the progressors to develop advanced disease. Also, in the light of landmark studies, we know that IOP reduction is of paramount importance. In fact, AMGT has shown a hazard ratio of about 1.1 per millimeter of mercury. So the popular arguments that are touted against the structural test is the red disease, which is because of high false positives and the low specificity. Again, this knowing the basics really helps in differentiating red from real disease. That is a thorough knowledge of the normative database of the machines that we are dealing with. A systematic approach to OCT interpretation, especially concentrating on clinical correlation and knowing the artifacts which the OCT can produce also helps in combating the red disease. Also, the other argument would be the floor effect. It is now known that the papillomacular bundle is more resistant to damage, and hence GCL-IPL shows the potential to identify structural progression even in advanced diseases, which decreases the impact of floor effect. So how does a functional test score as far as the advanced glaucoma is concerned? So it's been stated that when the mean deviation loss is less than 20 decibels, again the test-retest sensitivity fluctuation is much higher, as seen by the coefficient of variation, which is about 13 to 28% with visual fields. So the other limitations with the functional test would be that it is subjective, and we know subjectivity is a bane of any disease management. Interpretation is complex due to complex jargons like learning curve, variability, false positives, negatives, artifacts, fluctuations, etc. And also the other functional tests like SWAP, FTT, and ERG have not stood the test of time. 24-2 undersample central field, 10-2 does not have a GPA functional test. Though visual fields is a functional test, there is no importance to quality of life parameter, and this does not address the pathomechanism of glaucoma per se, and it's a relatively stagnant technology when compared to the amount of development that's been happening in the structural tests. And also patient factors like when there is a limitation to perform and it's quite time consuming and tedious. Some of them even put away follow-up considering the performance pressure. So the recent advances would be OCTA, which addresses the vascular pathogenesis, and the Brooks membrane opening, which is a more accurate measure of the neuroretinal rim, and RNFL reflectance has been shown to be reduced in early glaucomas. Again, of interest is the lamina cribrosa imaging, which is again a part of the mechanical pathogenesis of glaucoma. So we have the artificial intelligence and so the take-home message is structural tests have a valuable role in the detection of preperimetric, mild and moderate glaucomas. They only supplement clinical optic nerve assessment and should not be used in isolation. If read well, can be real. Due to the structure-function discord, it is recommended to monitor progression with both structure and functional test. So the newer structural tests have allowed for understanding of the pathomechanisms of glaucoma per se. So it is tried, tested, and also new. Thank you.
Thank you, Nagalakshmi.